I'm Dr. Shashidhar, and I'm a surgical andrologist. Definitely, I deal both with infertility and the sexual dysfunction aspects also. And yes, so what's the role of testosterone? Testosterone is the predominant male hormones. I'll say to my patient that it is responsible for you from head to toe. That testosterone plays an important role in your formation. So testosterone is a major androgen in males, which is responsible for fetal male sexual differentiations, pubertal development, and also the maintenance of secondary sexual characters, and not to forget the spermatogenesis. Compared to females, we have around 78% increase in the testosterone levels in the males. Testosterone predominantly is produced by the interstitial cell Leydig cells. Apart from that, a minor contribution from the adrenal cortex also. And yes. So what's the testosterone is mainly responsible for qualitative spermatogenesis, where it in fact initiates and maintenance of spermatogenesis. And anywhere where there is testosterone deficiency or a receptor deficiency, we end up with the arrest in spermatogenesis at the meiotic stage. And testosterone not only can inhibit the sperm's formation or generation of the sperm at the infantile stage, but also in a major subsequent pathways wherein some minor contributions in terms of the maturity, capacitation, and also the maintaining the total testosterone hormonal mildly. Okay. So now, also, we should not neglect estradiol is also equally important. Uh, and then later in the part of the talk, we also deal with decreased testosterone deficiency, its effect on spermatogenesis, also increased estrogen levels and its effect on the spermatogenesis. In males, estrogen is essentially secreted by the germ cells, adipose tissues, and small amount by the Leydig cells and also testosterone cells. And likewise, testosterone, estradiol is also required for germ cell propagation and survival. Not to mention, we should not neglect the part played by estradiol in this spermatogenesis process. So what are the essential steps? It is involved in capacitations, acrosome reactions. Apart from these functional benefit, it also has some tropic benefits like growth and development of Leydig cells, regulates cellular cell population and tight junctions, and inhibits production of androgen by suppressing utilizing hormones. So in higher levels, estrogens, it directly suppresses the Leydig cell function. In lower levels, it inhibits testosterone synthesis by negative feedback inhibition of the pituitary. So this again a simple, I think we all know. Hypothalamus secretes the gonadotropin releasing hormones where FSH and LH. FSH primarily acts on the Sertoli cells for spermatogenesis, and luteinizing hormones through the androgen receptors acts on the Leydig cells, thereby producing the testosterone. Testosterone, there are two ways to look at testosterone. One is the intertesticular testosterone, which will be discussing more enormously in the coming discussion, and part of the testosterone which crosses the blood testis barrier and goes to the outside. This peripheral testosterone is amenable for the measurement than the intertesticular testosterone. It's very much important to understand that we should focus more on the intertesticular testosterone when we are dealing with fertility, because most of the treatment strategies are aimed at increasing the intertesticular testosterone. So, just to kind of brush up, cause of male infertility is primarily into four categories. One is the primary hypogonadism, where the problem is within the testicles. Secondary hypogonadism, where the problem is within the higher levels. Post-testicular defects, mostly organic and obstructive pathology, and the unknown etiology. It contributes majorly where still we have reached a blinded as to understand where things are really going wrong in infertility. And yes, definition of male infertility. There are many societies which has come forward, and they're in the own way have defined the male hypogonadisms. Both ISM and European unions have kind of defined where it's a clinical and biochemical syndrome associated with low testosterone. So the common factor is the low testosterone and the associated clinical syndrome. From a fertility perspective, which we'll be dealing today, what is it defined? So, clinical syndrome that results from the failure of the testes to produce physiological concentration of testosterone which is associated with abnormal number of spermatozoa. So what does it mean to say? That is a array of symptoms. There is a syndromic problem where there is primarily decrease of testosterone, because of which there's secondary decrease or abnormalities is found in the spermatozoa or the semen analysis. But most of the times we always end up with multiple levels of problems, and from a clinician perspective we should not only looking at the testosterone, we should also look at other problems which can contribute to infertility. So again, so I'd like to highlight most important reasons we causes we see in a day-to-day practice. Primary hypogonadism, where the problem is within the testicles, we commonly see is Klinefelter syndrome, antecedent testis, varicose predominantly. In acquired causes, we see most probably mumps and cirrhosis, renal failure, HIVs are relatively rare. Obesity is one of the most common reasons. Hyperthyroidism, not very frequently. Medications, yes, we once in a while we see cases radiation therapy where people have undergone treatment. Most common is lymphomas in the childhood. They have undergone chemotherapy. Sometimes people coming with orchidectomy and subsequently undergone chemotherapy for testicular tumors. And obviously, which cannot be neglected, is environmental toxicity, trauma to the testicles. Second hypogonadisms, where we have seen not very commonly seen congenital. Acquired, yeah, we get to see more, where in acquired hypogonadisms, as defined, there is suppression of gonadotropin from the higher levels, and subsequently there is damage to the gonadotropin cells. What are the common reasons? Trauma, surgeries, radiations, tumor and cyst, especially like brain tumors, any other tumors, and usage of corticosteroids, opioids, chronic illness, and hyperprolactinemia. These are usually not very frequently seen in day-to-day practice. So, what is the basic pathology in everything? I would like to kind of focus more on the, I'll just keep it very simple. In primary hypogonadisms, where the problem is within the testicles, there is reduced spermatogenesis and there is reduced to normal testosterone levels. FSH levels may be equivocal, or sometimes it may be on the higher side. In most of the cases, the FSH is on the higher side. This is called as a primary testicular failure. So the primary pathology is within the testicles. In secondary hypogonadisms, the primary pathology is within the hypothalamus or the pituitary gland, always characterized by a decreased or a low FSH LH levels and reduced testosterone concentrations, consequently to the low gonadotropins, and all resulting in the reduced spermatogenesis. So post-testicular, mostly, obstructive variety, CBAVD, like infective causes, gonorrhea, more commonly seen chlamydia, tuberculosis surgery, and absence of ejaculate, spinal cord problems, especially quadriplegia, spinal cord surgery, transections below S2 levels, trauma and diabetes are the more common reasons for post-testicular. Diabetes can cause neuropathic or retarded or delayed ejaculations or anejaculations. So, what are the clinical practice guidelines says? So, whenever patient comes with infertility, it's very much important for us to not only from a clinical examination, we should also ensure that a person is totally or comprehensively screened, both by clinical as well as subjecting him to the hormonal profile, especially FSH, LH, testosterone profile, estradiol, and scrotal Doppler ultrasound to rule out. Though the guidelines says that Doppler ultrasound may not be the initial rule. I mean, initial what you call the mode, but based on your clinical findings, Doppler ultrasound can be applied. And what are the candidates? People who have concentration less than 10 million sperms, they need to be aggressively evaluated. And hormone evaluations, especially what are the we need to look into the what are normal levels. We more predominantly see to total testosterone, which is between 2.8 to 8.0 nanogram per ml. Free testosterone, it's around 3 to 34. Viable testosterone, estradiol 25 to 60, prolactin. Okay. So free and bond, of course, free, which is predominantly very vital for spermatogenesis, is the free testosterone, which is the most active form, which is responsible for the androgenic effects. So it's again probably a screenshot where the testosterone levels, where the total testosterone, which is nothing but a reflective of the testosterone bound to sexual hormone binding globulin, it may range from 44 to 60%. The free testosterone or the active form is comprises only 2% of the testosterone. So testosterone, it stands out as the best single test to diagnose the hypogonadism in male infertility. But we have challenges. I mean, it's not like hemoglobin, we have 14 to 17 in males. it's universally accepted yet. But that might not, kind of apply to testosterone. Every lab has their own way, own methodological way. The many assays like ECLIA, LSS, spectrometry analysis. So all these things, many labs have their own methodology of doing their testosterone evaluations. So you cannot just have a single number for a testosterone. So basically, whenever you read a testosterone level, it has to be according to that particular lab. So it's very important, though the testosterone stands out as the single best test, but it has many methodological flaws. So it becomes important for us to interpret according to the lab. And of course, free testosterone and biological testosterone is very important. When free testosterone, biological testosterone becomes very important when we have a doubt or you are skeptical about the testosterone levels. So, sex hormone binding globulin again. When this testosterone SHBG is utilized, so it is particularly helpful when the total testosterone levels are inconsistent with the clinical symptoms, and he is symptomatic, but the testosterone level seems to be normal. So in that case, SHBG comes into the picture. That's where we have to see for the total testosterone profile. Otherwise, majoritarily clinicians would want or would probably write down or expect just testosterone, both testosterone and total and free. But when you are doubtful about the testosterone, maybe you can use it of SHBG also. So, one more thing, testosterone to estrogen ratio, the level very importantly nowadays we're using predominantly when you are treating a patient with azoospermia, especially non-obstructive azoospermia or oligospermia less than 10 millions. What is the ratio between the total testosterone in nanogram per DL to estradiol, that is E2 in picograms per DL, and the cutoff level is 10. Anything less than 10 is something which is not a good news. So this again, what you call the cycle. Cholesterol is the basic hormones, and we have the one is the glucocorticoid pathway. Next is the steroidal pathway. That's so pregnenolone is a basic thing, and it is converted to 7-OH pregnenolone, progesterone, which is then converted to androstenedione, which is converted to intertestable testosterone. Intertestable testosterone, it is crosses the blood-brain barrier. It goes to the periphery. In the periphery, it is either converted by 5-alpha reductase to DHE, dihydrotestosterone, which has androgenic side effects. And other part of testosterone by the activity of aromatase is converted to estradiol. This estradiol can suppress the pituitary and further cause the decreased secretion of luteinizing hormones. So yes, intertestamental hormones is very much important for us because they say, see, the levels is around. Lot of studies have shown the levels is around 793 nanomole per deciliter, compared to the peripheral, that is the systemic testosterone 16.9 nanomole per liter. They say when this level decreases by to even up to 75%, lesser than 75%, there is a cease in sperm production. So it's very much important for us to ensure that whenever you're treating a case of for infertility, it is always directed towards increasing the intertesticular testosterone. Okay. So, so how do you monitor the intertesticular testosterone? So here, we cannot directly monitor the intertesticular testosterone. Previously, there were lot of invasive methods like percutaneous testicular aspiration, testicular biopsy, and what you call separate the testicular fluid and try to study the levels of testosterone within those fluid. But this is being an invasive, it can cause repeated what you call it, puncturing of the testicles, can cause injuries, fibrosis, hematoma formations, infection also sometimes could lead to infertility. So in order to overcome these side effects of invasive method to what you call evaluate the intertestamental testosterone, we are coming to something called as 17 hydroxyprogesterone, 17 OHP. A lot of studies nowadays have been kind of in the pipeline to estimate the what you call the levels of 75 hydroxyprogesterone, which can reflect intertesticular testosterone. And a lot of studies have proven that, which we'll come to know in the future in the coming slides. So indications would be to monitor the response of men with hypogonadism, and response of the infertile men with testosterone deficiency whenever they're treated with clomiphene or HCG. So, a lot of studies where they have made what you call the baseline evaluation of ITT with 17 OH progesterone, which is a reflection of intertestostal testosterone. So which can be used very easily also, and it's a very commonly available test which can be done by most of the clinicians. So there was a study. You can see here in the left side of the in the slide, the black row would be the less than 5 to 9, and more than 9. There was a study which was done around for more than 200 300 cases where the total beta sperm count was used as a criteria to see the improvement. Okay, so traditionally what we do is like the total beta sperm count is between categorized into three categories. One is to less than 5, 5 to 9, and more than 9. Less than 5 are the people who are the candidates for an IVF. 5 to 9 were the candidates for an either IUI, and more than 9 can candidates for everything IVA, IUI, IVF, or even they are candidates for natural pregnancy. So this group of people were taken, and they were treated, and you have seen that when they were monitored with the 17 15 OHP, there has been decrease in the less than 5% total motility sperm count as increase in the motility sperm count. And that this has been very consistent, related. So this is that increase in 17 OHP is associated with increase in total motility sperm count. So here the main criteria they have taken is the total motility sperm count, and I've seen that as the 17 OHP increases proportionally, there was an increase in total motility sperm count. So what's the take home message? 17 OHP should or should not be used is up to the clinicians, decisions. But in studies have proven that 17 OHP can essentially help us in trying to see or monitor the progress of a particular disease. So this again, how to evaluate a case of hypogonadism. Usually they say that testosterone should be taken in the morning, 7 to 11 a.m. in the morning. But this rule may not, but a lot of studies have proven that I think it's very important we should discuss here. They say everybody says that 7 to 11 a.m. is the best way because to take your testosterone levels. But even a single meal of glucose can increase the testosterone to more than 25 to 30%. So they have seen that they compared the variations, let's say circadian or the diurnal variations of testosterone, morning and evening. They've seen that by the end of the day, the results may be 25% vary. So it's always better to take these reports in the higher levels. But having considered that patients with a lot of stress, obesity, and other illness, metabolic syndrome, they've seen that this diurnal variations is not consistently seen. Okay, and especially people beyond 30, they've seen that now previously what is taught to be 40 years and above, where the diurnal variations slowly gradually is not seen. That shift is beyond towards the younger age group because of our lifestyle, and also the development of other metabolic problems. The loss of diurnal variations is not that great in the younger age group also. But as traditionally we'll go with the 711 a.m. testosterone. If it is normal, then with hypogonadisms, we'll always look for the other reasons for hypogonadism. And if it's equivocal, we should leave it. Yes, the testosterone is less than 300. Now, lot of studies, what is the low testosterone? As I told you, initially, most of the lab gives between 250 to 750, 800, 900 is a normal range. But what is the clinical significant value of a testosterone? And most of the studies have come to a common notion that less than 270 should be considered as a low testosterone. But yes, for that academic people purpose, people have taken as less than 300. So that's so. I mean, this is a normal way, and if it is less than 300, exclude reversible causes like and repeated testosterone between 2 to 3 weeks, and also at the same time, measure LH and LH to see is there any higher level of testosterone deficiency. If it is normal, follow up. If it is in this case, if it is low testosterone, high FS and LH levels, it should be considered as primary hypogonadism. Probably the problem within the testicles, like late onset hypogonadism, Klinefelter syndrome, other acute conditions like probably varicoses, trauma, many infections may be causing primary hypogonadism. If it is low testosterone and low to normal FSH, then look for second hypogonadism, probably at the higher levels in the brain levels. Look for a higher in modalities of investigations like MRI, prolactin assessment, and transferrin assessment. So yes, when we are talking, we should also discuss about the exogenous Testosterone replacement. I think Dr. Salechi will talk about the testosterone and the sexual dysfunction. So nowadays we are getting to see a lot of people who are into exogenous testosterone, and testosterone is most commonly used for one is the or anabolic steroids, people who are into muscle building and especially the athletes and other androgenic purpose are part of a TRT. And testosterone replacement, that is a TRT, is a good thing in a way, but to some extent, if you are still in the prime of your age and trying to have a baby, testosterone can also affect the fertility. How it can affect the fertility? It can affect the fertility by negative inhibition of the HPG axis and also reduction in the endogenous and intertesticular testosterone levels. So exogenous testosterone can reduce the endogenous and the intertesticular testosterone. It also causes atrophy of the germinal epithelium, okay, and thereby reducing sperm production, or it can lead to oligo or azoospermia. And we have studies have shown that people with exogenous testosterone therapy, they have reached azoospermia as early as 10 within 10 weeks after starting a treatment. But good thing is like the spontaneous recovery is possible after stopping the treatment, and many studies have showed that up to 80% of the people will see a spontaneous recovery within 110 days. So, but who people who are planning to for pregnancy, testosterone should be discouraged. So it's now not a good idea to use testosterone. So, testosterone replacement therapy. So, I mean, my topic is something in testosterone replacement therapy for infertility. It was somewhat confusing. I had, in fact, when Mahendra came to me with the topic, testosterone replacement therapy for infertility. Yeah. I mean, yes, testosterone replacement in case of infertility, where we are, is a diagnosed or a case of testosterone deficiency. So, what does it say actually? So, the principle would be to raise testosterone while maintaining the fertility. So, we have seen that when you are looking at a case of infertility due to testosterone deficiency, every effort should be made to raise the intertesticular testosterone, endogenous testosterone, and that is through triggering the endogenous production of testosterone rather than putting them on external testosterone. And yes, universal rule, strict no to exogenous testosterone. But yes, it's the other way. You're not trying for a baby, but if you want to maintain fertility, exogenous testosterone can be continued, but with some other medication, it can be added as an add-back therapy so that spermatogenesis is also maintained while is on testosterone therapy. So what are the treatment options? There are many treatment. One is like we have these selective estrogen receptor modulators, the SERMs, aromatase inhibitors, HCG. These are the three levels which probably the strategies to kind of increase endogenous testosterone, which have their own way of mechanism of actions. First, we'll talk about the SERM. Okay.
Proceed, sir. 5 minutes,
Yes.
sir.
Yeah.
You still have 5 minutes time.
Natesh, I'm sorry if I take much of your
No
time.
problem.
Yeah,
Just inform
please
me.
give me, pardon me, because 15 minutes, I think, I'm not sure. So I hope you will understand. So we have more commonly used clomiphene citrate and tamoxifen citrate, most commonly used. Okay, clomiphene citrate and tamoxifen citrate, they act as estrogen antagonists. We all know that testosterone is converted to estrogen, which it competes with, which inhibits the LH production by inhibiting the hypothalamus. But here, clomiphene citrate can and tamoxifen act as a estrogen antagonisms, where there is increase in pulse frequency of gonadotropin, GnRH, FS, and LH levels. This is the basic mechanism. They act as estrogen antagonisms. So clomiphene citrate has been always been the first choice of treatment because it is off-label usage, so there is no consensus regarding the dosage. Okay, so whenever there is an offline usage, usually the dosage is not considered. I don't know how it is, but but traditionally we've been using 25 milligram, 50, 100 milligram. But usually most commonly people tend to use 50 in extreme cases 50, not 100 milligram. I've not seen any people using 100 milligram. And in hypogonadism and oligospermia, it's so CC can be used as a monotherapy. So clomiphene citrate is most studied and generally considered as a first line treatment. And tamoxifen preferred by some. There's always a debate between use of clomiphene as or a tamoxifen. Clomiphene has most of estrogen side effect that can be paroxysmal, whereas tamoxifen can be used. It comes in 10 milligram, can use half a dose or probably a 10 milligram full dose, where the estrogenic side effects are less with tamoxifen than compared to clomiphene. It's very important. So again, a lot of people have done a study. This is a landmark study where 4,000 cases, 4,000 studies have been taken. Sorry, and they've seen that 59.9, roughly 60% of the people have improved when the CC was used as a single most common drug. So we have seen that there has been an improved pregnancy rates, either spontaneous or with assisted reproductive techniques. But yeah, most of the studies where we have limited or downsized to at least 8 studies, most of them we used either 25 milligram or 12.5 milligram. There was only one, Mikey et al. Was used 50 milligram for 6 to 9 months. Duration of treatment, not more than 6 months, according to this study. So again, same study where they have compared clomiphene citrate, meslorone, pentoxifil, and testosterone, and if clomiphene citrate stood out with a pregnancy rate of 36 to 22% over a period of 6 months. So what are the outcome measures? Increase in mean sperm concentrations. It also increased motility and morphology. But definitely, this also put there's no enough evidence to evaluate the use of androgens for male infertility. Strictly no, sir. No androgens for infertility. Side effects, again, gastritis, hair loss, gynecomastia, very rarely venous thromboembolism. It should very because we're using for 6 months, venous thromboembolism should be kept in mind. Whenever the patient comes in, leg pains and all, we should always taken care. Gynecomastia because of estrogen side effects. As I told you, paradoxical side effects. That is because of the hyperestrogenemia, which again acts as an aromatase inhibitor, but it is safe for long-term treatment. As conclusions, most popular drug, low cost, oral, and the first choice for empirical treatment. Again, the same thing, safe therapy. Yeah, next comes to aromatase inhibitors. So aromatase inhibitors, it converts the C19 androgens to C18 estrogens. So where the testosterone is converted to estrogen by the aromatase, and the aromatase inhibitors block this step. So aromatase inhibitors are expressed in Leydig cells, Sertoli cells, germ cells, and it's also expressed in epididymis. So yes, coming to side effects, aromatase deficiency, tall stature, skeletal maturations, epithelial closures, bone pain, and excess adiposity. And I mean, in my practice, I've seen that a lot of parents come, with their children age between say around 10 to 14. Doctor, I think I believe that my son's sexual genital is not grown to the extent. I mean, we are very concerned about it, and we believe that actually we should evaluate, and we do a certain amount of hormone evaluations. Of course, according to the levels, we also look for the opinion sales expert as per the chart. And one of the most common treatments, like not to use testosterone directly, we always indirectly try to increase the endogenous testosterone, where there's always a tendency to use the clomiphene citrate, or to probably also use anastrozole or aromatase inhibitors. And we have seen patients coming, doctor, I think my son is growing day by day, doctor, tall. So very important that tall stages to be considered in people, young people, where we believe that there is delayed onset of puberty, or the hypogonadisms, using aromatase inhibitors, where you always either you have a choice to use aromatase inhibitors. I can use HCG, because here you should make it a point that spermatogenesis should not be affected in any way by using testosterone injections or in testosterone preparations. So, estradiol, as I told previously, estradiol is essential for motility, capacity, and axonal reactions, and fertilizing capacity. Excess estrogen can cause negative feedback inhibition, which is where the aromatase inhibitors act. It relieves the excess negative feedback on the axis, and thereby increases FSH, LH, and testosterone production, restores spermatogenesis and Leydig cell function. That is the role of aromatase inhibitors. So again, it's an off-label use, empirical treatment, and usually I prefer to use anastrozole, because letrozole has its own, burden. So I usually tend to use anastrozole either 1 milligram alternate days or every day. So indications would be azoospermia, oligospermic acids, and cryptospermic acid with low or normal T ratios. So outcome measures, aromatase inhibitors, a lot of studies, prospective and retrospective studies have come with outcome measures. And we have seen with use of aromatase inhibitors, there has been significantly increased levels of T ratios, significant increase FS and LH levels, and some azoospermic patients have even become functional by having some sperms in ejaculate, which is a very good thing to in such treatment, because we can avoid, if the whatever the sperms is pushing out in the ejaculate, if we can probably are able to freeze it, maybe the patient can avoid the invasive procedures like TISA and its subsequent complications. So sometimes adding chromium citrate can also add to the problem where when you suspect hypogonadisms. And aromatase inhibitors, most common problem is decreased libido, mild elevated liver enzymes. Otherwise, some people might really come with alopecia. Otherwise, it's a safe drug. So, conclusions, it's safe, it can be used effectively to increase the endogenous testosterone. And last is HCG, human gonadotropins, which, okay, fine, this is where, okay, again, yeah. HCG and LH share a common identical subunit where the half-life of HCG is around 36 hours, whereas the half-life of LH is 36 hours. On the basis of 36 hours we have used, we have always recommend the test. I mean, there should be rational to using HCG. Some people may say every day, alternate days, or maybe twice in a week. But based on the half-life, we always recommend the patient to use once in probably around 2 days, once in 3 days when you are trying to use HCG for this one. Indications for HCG, preserving spermatogenesis, which HRT. As I told you, this is the one which should be very important. If you are there is this absolute indication, you have to continue with TRT and anabolic steroids. Yes, make it a point that HCG is also added because HCG it increases intertextual testosterone and it maintains spermatogenesis in patients who are actually on TRT or testosterone injections. And as I told you, it recovers spermatogenesis post people who have used spermatogenesis and come to you with low sperm count. HCG can be considered as a safe option. It can be used in azoospermic patients and also severe oligospermia patients. So again, very important. This is an algorithm. So here, stop testosterone. So this is steroid-induced hypogonadism. Stop testosterone here. Then evaluate basically semen analysis, testosterone levels, FSH and LH levels, and estradiol levels. If in analysis shows oligospermia, please preserve it because what you have on table is the truth. Because we cannot predict how the testis predicts. Tomorrow you may not. There's something called variable azoospermia where patients might have sperm today, but after some time you might have sperm. Then I think you should not scramble in the last moment for a sperm. So whenever you have an opportunity, freeze a sample, then continue treatment. Treatment with what? HCG, 2000 units thrice a week. If you believe that there is a decreased FS and LH levels, add Clomid. Continue it for 3 months. After 3 months, again check semen analysis, FSH, LH, and testosterone and estradiol levels. If it is still oligospermia, please cryopreserve it. If it is persistent azoospermia, add FSH levels. Okay. Yeah, again, after FSH levels can be again can be continued for next 3 months. Cumulatively, it's around 6 to 9 months is the treatment. After 9 months, if you're able to have some sperms ejaculate, that is a good news. Freeze it. If there are no sperms, without taking a second thought, go for a TISA or macro-TISA and with a parallelly concurrent stimulations. So this is the algorithm. This is with hypogonadisms, with infertility. Other cases like infertile means with NOA, okay, and hypogonadism is equal to gonadotropin therapy. So always start with HCG in this case because here the problem is not with the FSLH levels, it's because it's a primary testicular failure. We start with HCG, and HCG is used for initiation of spermatogenesis. Subsequently, based on the protocol, measure every 4 to 6 weeks, and after 3 months, you again do the sample. If there are sperms, freeze it. If there are no sperms, add FSH levels. So here, always the principle is initiate spermatogenesis, then maintain the spermatogenesis. Initiation is always with HCG plus or minus CC, and if you want to maintain, add menotropies, either FSH levels. You do a semen analysis after 6 months. If there are sperms, freeze it. No sperms, you do a micro-TISA. This is the effective way. And yes, definitely, yes, we have seen that when you maintain initial testosterone levels of 600 nanomilligram, as you increase the testosterone levels, there's a very good chances that you are able to. In fact, we have a lot of cases ongoing where there has been an attempt to medically optimize them before taking a decision of micro-TISA. And I think we have had a very good success rate in trying to have some sperms in ejaculate only by medical optimizations. So it's again, clomiphene citrate 50 or 20 and HCG, same thing. So yes, with what does the study says that 11% of the people are able to have sperms post azoospermia. 11% of the people were able to have some sperms in the ejaculate, and 57% of the people with case of non-obstructive azoospermia, NOA, or primary testicular failure, there was 57 to 60% success at surgical sperm retrieval. Conclusion: research demonstrates that HCG is a treatment choice in azoospermic males. So, take home messages. Male fertility conveys a large social, psychological, and economic burden, and improvement with medical therapy could be a step towards personalized medicines. Thank you.